Hello, my name is Dr. Elias Traboulsi, and I'm head of the Department of Pediatric Ophthalmology and the director of the Center for Genetic Eye Diseases at Cleveland Clinic's Cole Eye Institute in Ohio, USA. Today, I'm going to discuss recognizing Stargardt disease, what every clinician should know. Well, Stargardt disease is the most common of the inherited retinal dystrophy and certainly the most common form of early onset macular dystrophy. It is a progressive disorder that leads to central vision loss, eventually to legal blindness. Most commonly, it's caused by autosomal recessive mutations in the ABCA4 gene. However, a minority of patients could have an autosomal dominant form of the disorder caused by variants in the PROM1 gene or the LOL4 gene. Pathophysiologically, the underlying mechanism is the result of sequence variations in this ABCA4 gene that codes for a protein called ABCA4, and it's a flippase. A flippase is an enzyme that takes a substrate from one side to the other side of the cell membrane, in this case, an RPE, from the cytoplasm to the lumen of the outer segment disc. And it binds it and flips it to the other side. And when it goes to the other side, then NRPE is hydrolyzed and it goes on to allow the formation of 11-cis-retinal, which is important for the visual cycle. When ABCA4 is not functioning well, and it does so to variant extent depending on the sequence variant, this whole process is disrupted, and there is accumulation of byproducts that are toxic to the cell. They're called A2PE, and this accumulation of these toxic products leads to cell death eventually, and to the clinical aspects of the disease. A large number of studies that have looked into whether different sequence variants within the ABCA4 gene would lead to different severities of the disorder. And indeed, that has proven to be the case, with some mutations resulting in a severe form of the disease with early onset, and others resulting in a milder form of the disease with later onset and eventual better prognosis. For example, a patient with a C5882G2A mutation can have relatively preserved vision late in life and have an onset of the disorder in their 20s or 30s. We have looked at this type of correlation in a number of patients in the past and published our results. On the other hand, patients with this C5461 minus 10 T to C substitution, that's usually associated with early onset disease. For example, a patient who's 10 years old, when they start having symptoms, can go on to lose all their vision by the age of 50. These are the less common situations. The onset could be in childhood, but more often than not, we see patients presenting in early adulthood, or they can even present in later adulthood, where the diagnosis then becomes a little bit more difficult because we do not think of that diagnosis when they are older. And many of these patients, these older adults, are misdiagnosed as having age-related macular degeneration. The clinician has to think of that diagnosis when patients present with progressive bilateral central vision loss. And that progression in children could be relatively rapid within a few months to a year. And in older adults, it could be much slower. And now we recognize that Stargardt disease has a wide spectrum of presentation, including, the development of a central scotoma. So right in the center of vision, patients will have gray, black, or hazy spots. Some patients are light sensitive. There's dysfunction of the cones, so that leads to sensitivity to light and abnormal color vision. And because it can also, actually, it does affect the rods, you can have delayed dark adaptation. And sometimes patients go through phases where they start out with one set of symptoms and progress into having others. When the ophthalmologist or eye care provider looks in the back of the eye, they will see macular atrophy and yellow-white flecks in the RPE, usually in the posterior pole, but they could be more diffuse in the fundus. The way it is better diagnosed clinically is using retinal imaging, and we now have a number of modalities that can demonstrate quite characteristic findings, including OCT, fundus autofluorescence, and when we look directly at the fundus with either photography or our instruments, we can see a lot of the time a classic fundus appearance with the foveal atrophy, the beaten bronze appearance, and the flecks. Sometimes patients present, especially the younger ones, with what we would call a bullseye appearance in the macula, and these are concentric areas of darker and lighter pigmentation that gives the appearance of a bullseye. And we should be able also to see flecks in the posterior pole. I have to warn you, though, that in a lot of younger children, especially right on presentation, the fundus may appear perfectly normal. And these are the patients in whom the diagnosis is initially not suspected. Well, I think most often it's because its symptoms overlap with other diseases, whether they're retinal diseases and sometimes optic nerve diseases that the clinician might think that the patient has. So Stargardt disease does not come to mind initially, especially in those patients, as I mentioned, the children who do not have flagrant flecks, for example, these deposits under the retina. If the flecks are present, then the disease is easier to recognize. More often than not, we do not run into an under-recognition as much as we run into a misdiagnosis as age-related macular degeneration. There is increasing awareness of Stargardt disease because it's widely taught about in training programs. The availability of genetic testing and the studies on genotype and phenotype correlations, and a lot of literature in the recent years about Stargardt disease is making this under-recognition being better addressed. I do not have to tell you how this distraught patients whose central vision is affected, it affects their daily life to a large degree. They may end up not being able to recognize faces, reading, utilizing their phone and their computer. They lose their independence, and they need a lot of supportive and adaptive measures in school or work, etc. So on daily life, the impact is quite severe. And on on the long term, they will lose income, they can become depressed, and just the fact of having this chronic disorder of their vision that affects their life goals, their personal ambitions, etc. So it's quite impactful on their daily life and long term. The delays and challenges and the diagnosis have shortened in recent years, but still many patients go from doctor to doctor trying to figure out why their vision is poor and a diagnosis is not made or a misdiagnosis is made. Finally, there definitely are some barriers to genetic testing, access to genetic testing, but I know this is getting better. In this section, we will talk about how to distinguish Stargardt disease from other retinal disorder. The major challenges in diagnosing Stargardt disease stem from an inability to keep that diagnosis in mind, especially when the age of onset it does not fit the traditional classic perception that clinicians have of this being a childhood disease. So in older adults, we tend to think age-related macular degeneration. In children, however, many times early in the course of the disease, the fundus may appear normal, and unless we proceed to obtain additional tests like fundus autofluorescence or OCT or a fluorescein angiogram, which we don't do anymore, or an electroretinogram, or even genetic testing, we might miss that diagnosis or delay it at least, because eventually there will be some retinal changes that one would see. Adults are often misdiagnosed as age-related macular degeneration, and indeed there are patients with Stargardt disease whose fundus appearance looks exactly like age-related macular degeneration. Additional factors include the lack of experience of the eye care professional in interpreting abnormalities that they can see either on ophthalmoscopy or even on testing. Children may not be conveying exactly what their symptoms are and are often dismissed as making this up. And we already talked about late onset Stargardt disease and its misdiagnosis as age-related macular degeneration. And there is in general more of a diagnostic delay in these older individuals than there is in children. We have been so lucky in the last couple of decades in that imaging technology has advanced so much and has allowed us to make this diagnosis a lot easier, especially with the advent of fundus autofluorescence. And that's a technology that allows the detection of this accumulated material in the retinal pigment epithelium, where in a situation where it's not supposed to, and in patterns that are easy to interpret as being a reflection of an underlying Stargardt disease. Also, optical coherent tomography, or OCT, is non-invasive, and it provides us with morphologic information about the retina in such patients. So the combination of the two allows a clinical diagnosis, especially when it's combined with the clinical presentation and the findings on ophthalmoscopy. The combination of these imaging modalities allow us to differentiate Stargardt disease, for example, from other macular dystrophies, including Best disease and other disorders that affect the macula, such as X-linked retinoschisis. Both of these will present in the younger age group, and there are very specific findings in each that would allow us to tell whether we're dealing with Stargardt disease or with Best disease or with X-linked retinoschisis. Electroretinography is not mandatory, at least in my practice, to diagnose patients with Stargardt disease. However, it does carry some weight in the prediction of a mild or a more severe phenotype. ERG is not readily available, it's time-consuming, it requires highly trained and dedicated clinicians, and for children it is long, and adults it is long and uncomfortable. So we'd rather not do it unless we have to. Genetic testing confirms a clinical diagnosis, and it is certainly the gold standard in diagnosing Stargardt disease. We have to realize, however, that the testing may not identify the sequence variant in all cases, either because of technical issues or because we did not use the appropriate molecular genetic test. These two limitations have been decreasing in importance recently because the labs that now provide genetic testing for patients with Stargardt disease have advanced a lot in their ability to detect all sequence variants. It is then the role of the genetic counselor and the role of the diagnosing ophthalmic geneticist or retina specialist to interpret the result in the context of the clinical findings and determine whether indeed the patient has Stargardt disease, even if the molecular test is inconclusive or negative. That does come up periodically, and depending on what test was done, we may or may not decide to repeat it. So when should we obtain genetic testing? The genetic testing should not be initiated until all the clinical information has come in, the workup has been done, the imaging has been obtained on the patient, and when the index of suspicion of Stargardt disease is high enough to proceed with it, or if the clinician is not sure what disorder they are dealing with. We often get a diagnosis of Stargardt disease on molecular testing when clinically we are suspecting something else, or where the diagnosis did not occur to us. Especially in patients who have signs and symptoms of what we would call a cone-rod dystrophy, and they turn out to have a Stargardt disease, or they have what we might think is an inherited macular disorder of unclear etiology. So we do not only obtain genetic testing if we are highly suspicious of Stargardt disease. We also obtain it when we are not sure what we are dealing with. And this is the beauty of precision medicine. Diagnosis, at the end of the day, is a combination of the interpretation of clinical findings, imaging results, and molecular genetic testing. We put all that together and then decide whether the patient has or does not have Stargardt disease. to improve the diagnosis, we need to get a good detailed clinical history. The eye exam has to be comprehensive and done by somebody who knows what the signs and symptoms of Stargardt disease are. And if all of that is not available in a particular setting, then these patients should be referred to the specialist. In this section of the program, we are going to discuss how we can enhance patient outcomes and how we can support strategies for patients and their caregivers and families in the setting of Stargardt disease. The best way of handling this type of aspect of limitation of vision in patients with Stargardt disease is to have them see the specialists in low vision. There are low vision clinics, and there are resources in schools and in the workplace that they need to seek when they want to improve their functioning. So I do think that the first role of the patient here, or the most important thing that the patient and their family need to do, is inquire about what is available in their immediate environment. And the eye care provider, the eye care specialist, should also know what's available so they can direct the patient to those. And fortunately, in this day and age where technology has made a lot of advances, we now have a lot that could be given to these patients in the form of electronic assistive technology. There are certain things that we recommend for patients with Stargardt disease, including avoiding vitamin A supplementation, because that could be theoretically toxic to the retina, although the final proof for that has not been documented. Additional UV protection may also help. Smoking cessation, of course, irrespective of whether they have Stargardt disease or not, they should stop smoking. But any retinal cell that is under stress from an underlying genetic problem is damaged even further with smoking. So basically, it's a combination of education, open communication, the use of low vision aid, assistive technology, mobility training if they need it, vocational rehabilitation. And we should not forget that these patients need to come in for regular eye exams, because they could develop something else that needs to be addressed. They can develop cataracts, they can develop glaucoma, they can develop other issues. They may need a good refraction and a new pair of glasses. So their routine eye exam, regular eye exam is critical. And many times, some of these patients, when they know nothing could be done for them, they lose interest and they don't want to come back because they're kind of have lost hope that something could be done for them. Finally, there are a lot of networks that are available depending on where the patient lives and what country they're in, that they can also get hooked to, and this way they communicate with others with the same problem and learn from them and be more aware of the resources they have. So these support groups are very important. And evidently, the patient has to understand their disease well. All patients who have vision loss are worried about one major thing. Are they going to go blind? Are they going to lose all their vision? That's the most common question we get as ophthalmologists who care for patients with Stargardt disease. And it is extremely unlikely that a patient with Stargardt disease would lose all their vision. It can happen, but it's very unlikely. Certainly in those patients in whom the disease made itself manifest later in life, they tend to have a slower course of the disease. And many times that's all they want to hear. But the more educated they are and the more educated the eye care provider is about this, so that they can convey to them the appropriate information, the better the patient's well-being is going to be. As I mentioned earlier, the best professionals to take care of that and decide what the patient needs are the low vision specialists. And from our end, as ophthalmologists and optometrists and other people who take care of these patients in clinic, what we need to know is that this is extremely variable, depending on age, depending on visual needs, depending on stage of the disease, etc. So the best thing to do is to send them to the low vision specialist and to the other members of the team that need to take care of them, take care of their well-being, take care of their psychosocial problems that arise from having this disease, make sure they're hooked up with the genetic counselor, so that if they have questions pertaining to family planning or recurrence risks in siblings or children that are a source of anxiety for them, that somebody who is a professional would know how to answer those. So it's critical to have this multidisciplinary approach, so that you have an individualized care for the patient, and the team consists of the eye care specialist, the social worker, the psychologist, the occupational therapist, the geneticist, and if they are in children as opposed to being adults, then there are other members of the team, like educators and child neuropsychologists and pediatricians who need to be involved in the care of these patients. So just to summarize, we need to address the biological aspects of the disease. We need to address the psychological aspects of the disease and the sociological aspects of the disease. And I hate to admit it, but many times the eye care specialists kind of overlooks some of these and focuses more on the medical aspects of the care of these patients. So just keep that in mind as you take care of your patient with Stargardt disease. Counseling and communication are some of the more difficult aspects of clinical care. And when I say clinical, I'm not saying only medical clinical care. So one has to have experience, one has to be trained in communicating with patients who have genetic diseases. And in my mind, the genetic counselors and the clinical geneticists are best positioned to do that, because they have been trained to give clear and compassionate communications, set realistic expectations if they know what to expect, or say that we don't really know. Just be clear and direct. And these are the individuals also, the genetic counselors and the clinical geneticists, who would know more about patient groups and networks and vocational rehabilitation services, and they can direct the patient to where they need to go. And of course, the individual's own insights and experience is always infused into their encounter with the patient and their communication with the patient. Unfortunately, we still do not have any approved treatments, whether in the US, where the FDA is the body that approves them, or in any of the other countries in the world. However, it is looking up. There are a number of therapies that are under investigation, some of which have shown initial promise. There are some oral medications in trials. Gene therapy is also underway. We do not have any efficacy data to date. However, gene therapy for other retinal diseases have been shown to be at least safe and has been efficacious in treating some of the other retinal disorders. Stem cell therapy is another venue to take care of these patients, and it's still under investigation. We do not have any efficacy data either. The adaptive technologies and digital resources have been phenomenal and have made a major impact on the day-to-day functioning of patients with Stargardt disease. And I suspect we're going to see even more of these advances as time goes by. When we think treatment, we have to think, how can we stop the problem? How can we stop this disease? And of course, is there any way of actually regaining some of the vision that we've lost? And we do not have any current answers to this last question, but we are going to have them soon.